Welcome to your lecture over the second part of the anti-infective, anti-inflammatory drug. We will have a quick reflection here, a little Irish blessing, although it's not St. Patrick's Day. I still kind of like this one. Always remember to forget the things that made you sad, but never forget to remember the things that made you glad. Always remember to forget the friends that proved untrue, but never to remember those who have stuck by you. Always remember to forget the troubles that passed away, but never forget to remember the blessings that came each day. So we're going to be covering chapter 40 and 42, which is antiviral drugs and then antifungal drugs. These are two topics which could be really in-depth, particularly antiviral medications, because it's a complex process that these drugs go through. However, since most of you guys are not going to really be working in this field, I'm just going to give you the general overview that you're going to need to be a safe practitioner. So we're going to focus a lot on the broad concepts and kind of just get your toes wet on the subject. Should you decide to specialize in antiviral therapy, say you work in a clinic which might specialize in viruses, or in an infection control setting, then you'll learn a lot more about this. But just for the general nurse, general practitioner, general PA, general NP, this will be a good introductory into what we're going to do. As far as describing the effects of viruses in the body, you guys can read through that in your book. It does a nice job. I'm not going to take a ton of your time while we listen to this outline. We're going to talk about drugs which are used for non-HIV antiviral agents and then the antiviral agents specified for HIV, because it's completely different mechanisms of actions and drugs. So we'll talk about non-HIV and then HIV stuff. Talk a little bit about immunosuppression, how that affects the care. Talk about the different stages with AIDS and HIV patients, and then we're going to talk a little bit about mechanism of action, interactions, and so on and so forth of the different drugs. So to start, what is a virus? A virus is simply a microorganism which needs a host to replicate, which makes it a parasitic agent. Within this parasitic agent, you have a viron, which is just the mature virus particle, and that viron finds its way into your body, whether it's through the nose, eyes, mouth, open wound, wherever, it finds its way into your body. From there, it fuses with a host cell. Now, some of your antiviral agents are going to work right here at that fusion, so that will be important to remember. Otherwise, it fuses with the host cell, and then the virus replication will take place. Now, once replicated, the new virons exit their host cells, and then they start infecting other cells. So then it starts growing from wherever it started to the surrounding tissues. The viron can reproduce thousands or millions of times prior to the onset of symptoms. And this is why we say somebody might be infected prior to them having any clinical manifestation. So you might have the flu before you actually show it. You have that phase where you don't really have symptoms, but you could still be transmitting the disease. And this makes treating viruses a little bit more difficult. Because a lot of times the virus is fairly widespread, not so much for like influenza or like shingles and those viruses, but for like HIV, it makes it difficult because the best time to treat it is in the stage where it's replicating but not having clinical manifestations, and most of the time people don't know they're diagnosed at that point. So that's what makes treating it a little bit difficult. The other thing that makes treating viruses difficult is that antiviral agent must penetrate the host cell, and this is really difficult for our drugs to do without actually killing the host cell. So if we were just talking about a handful of cells, it wouldn't be a big deal, but if you think that it's already penetrated millions of your cells by the time you start feeling crappy, we really don't want to kill all millions of those cells if we don't have to. But that's one more thing that makes the viral infections a little bit more difficult to treat. Once the virus gets in there, eventually the host cell will die without intervention. So sometimes it's a lost cause on whether or not our antiviral agents need to kill the host cell or if it can just slow down the replication. And once enough host cells die, then the host organism is going to become sick and then eventually die as well. One more term for you, an oncogenic virus would be simply a virus which results in malignancy, and it works similar to how we just described about fusing with the host cell and replicating, except for with the oncogenic, when they replicate into the RNA and DNA, which then causes more problems. That'd be like the HPV virus that most people, I think, are getting vaccinated for at this point, would be an oncogenic type virus. So as far as treatment goes, typically the immune system is going to identify that virus and eradicate it before any medication is needed. So a lot of just like your stomach flus, your influenzas, head cold, stuff like that that's caused by a virus, for the most part, those go away without any intervention needed. Even chickenpox, once upon a time, no intervention was needed, although now we vaccinate against it. So most of the viruses really don't need any help, but sometimes there will be a couple specific instances when the virus doesn't go away, such as the case with like HIV, or herpes simplex is another one that doesn't go away. That would be the time when you'd use an antiviral agent. The other time you'd use an antiviral agent is if you have a patient who is severely immunocompromised and their immune system can't overtake it, whereas a healthy person's could. So therefore, our antiviral agents are going to be reserved for patients who are immunocompromised or they have a specific type of virus that doesn't go away. I lost my train of thought. So exactly how do they work? Well, they're going to work one of two ways. They're either going to kill the virions. However, when they kill the virions, they can't completely kill everything. So there are some virions that do survive, and then typically the immune system steps in and does the rest. So like if you're giving an antiviral for the case of influenza, that antiviral is going to kill most of the virions, but then the immune system still has to come in and kill the rest. The other way these work is to inhibit the virus' ability to reproduce, and the same thing here. Some are still going to reproduce, so the antiviral will come in and wipe out most of them, but then still the immune system's job to come in and wipe out the rest of them. I have a couple different types of viruses that we treat listed there. Cytomegalovirus is called CMV for short, and that is something that typically arises for patients who have AIDS. Hepatitis is actually a virus some types of hepatitis we can cure and some we can't. Herpes we can't cure, but we can control. HIV we can't cure and we can only loosely control. And then influenza we don't necessarily cure it, but we can reduce the length of symptoms on that. And RSV is another one that we can try to reduce the length of symptoms on. Again, your antiviral agents don't completely eradicate the virus, they just reduce either the amount of virions that are living in the body, or they inhibit the process for that virion to reproduce. And then we depend on the immune system to still come in and clean it up. And typically the patients who are going to get an antiviral are those who are immunocompromised or who have a particular type of virus. The immunocompromised patients would be like patients with HIV and AIDS because that's a virus that wipes out your immune system, so therefore it's compromised and it doesn't work so well. Other types would be organ transplant patients. It's not the transplant itself that makes them immunocompromised, it's the medications that we give them to shut down the immune system so that they don't reject their new organ. So we still call them immunocompromised, although it's the medications we're giving to prevent a rejection that cause them to be so. So they're at a high risk of developing an infection. Same thing with the cancer. It's not necessarily the malignant tumor that makes them immunocompromised. It's the chemotherapeutic agents that we give them to kill the tumor. Typically also kills a bunch of the other cells. And within that causes bone marrow suppression, and then that also wipes out the immune system. So we have this divided into two separate sections. First, we're going to talk about non-HIV and AIDS viruses. We're going to talk about like herpes, varicella, influenza, those types of viruses. And then we'll talk about HIV and AIDS a little bit separately. So just starting off, as far as the pathophysiology goes, we're just going to barely touch the surface because, again, if we really wanted to, we could spend an entire 3-credit course just talking on how these viruses replicate, which eventually I assume you're going to take pathophysiology and learn a lot more about that. So just starting right now with the herpes simplex viruses, it's abbreviated to HSV, and there's HSV1 and 2. HSV1 is going to be the periorbital blisters, or the sometimes known as cold sores or canker sore. And this is just a virus that only affects the tissue kind of in the periodontal area, lips, mouth. Some people get them really bad, like within their mouth, and some it stays retained to the lips. But once it's passes, it causes these open sores there. HSV2 is similar to HSV1, except for it only affects the genital area, so it results in like a genital blister. They're both spread through direct contact, so like HSV1 could be spread through contact of an open sore on the mouth, such as kissing, using chapstick, using the same drinking glass as somebody who has an active wound or an active lesion. Genital blisters then would be spread through direct contact via the sexual intercourse, but it has to be a direct contact. These viruses don't live very long on a surface area, so if it's spread like via chapstick, it has to be something where they use it and then quickly somebody else uses it to spread that. So for the most part, it's spread through direct contact, but it could be spread through the shared use of other types of stuff that you shouldn't be sharing with people. As far as the clinical manifestation, this virus itself is not deadly, but it's highly uncomfortable. And if you've ever had a cold sore, you know how painful they are. It's typically a painful lesion or a painful blister, and from within that lesion or blister, weeping occurs. It's that weeping that actually causes the transmission of the disease. They typically go through a relapse and remission, which means they come and go, and it can only spread when the virus when the blisters are present. But the tricky thing is, like especially with genital warts, the virus might be starting to become active and it'll be spread through the genital secretions, but it might not actively be there. So it is possible to spread the infection without an open sore, depending on where in the cycle that virus is at. If it's starting to fall into a relapse or it's becoming more active, it can be spread, but it's most likely to be spread when there's an active open lesion there. As far as our treatment, again, we can't cure either of these strains, so our treatment's going to be aimed at speeding up the relapse into remission and then keeping the patient in remission. So essentially to reduce the frequency and the duration of attacks. To do this, when a patient has a relapse for either strain, we're going to give them a higher dose of medication. And then to help prevent a relapse, we'll give them just a low dose to keep them in remission. Again, it does not eradicate the virus, but we can help control the symptoms and hopefully help prevent the spread, especially of the second strain of virus. Try to help spread that strain around. The next non-HIV virus we're going to talk about is typically known as chickenpox or shingles, and that's the Varicella zoster virus. Shortened to HHV-3. Where they come up with the HHV, I don't really know. Essentially, it's chickenpox in children, but chickenpox in children then becomes shingles in adults. Chickenpox itself is very transmittable, but it's a very self-limiting virus. So once upon a time, parents actually used to take their kids, if they heard somebody had chickenpox when they had little kids, they would take their kids to play with the sick child, so that you would get the chickenpox when you were young and didn't remember it. And then you were immune from getting it when you were older, was the thought process. Now that virus does lie dormant in the body, so then in adults during stressful periods or if a trigger happens, then it comes out as shingles. There's a hypothesis that now that parents are vaccinated against chickenpox that we might actually be able to eradicate shingles as well. But the chickenpox virus was just approved in 1995, so it'll take a while for the babies from 1995 on to grow into adults to see if we do actually eradicate the shingles virus. But if we could, that would be beneficial to society because shingles is very painful. So shingles is simply a dormant chickenpox virus, and it manifests itself as a skin lesion which follows a dermatome. And I meant to grab a picture for you, but if you don't know what a dermatome is, just Google it. Go to Google Images and type in dermatome, and you will see that your nerves they go down centrally your body by the spinal canal, but then they branch off fairly linearly. what shingles does is it'll jump on one of those sprouts off and then it'll follow it. So it's not unusual to see like a rash of shingles start at the forehead and then just stay parallel and run around the head, or down an arm, or around the trunk, or down a leg, but it'll follow those dermatomes. So it's not going to be a widespread rash, it's going to be a very localized linear thing that follows that nerve route around the body. Now these are because they're on a nerve, it causes a lot of pain. It causes a lot of nerve pain, which feels like a sharp stabbing, shooting, kind of think of a root canal, like if a dentist were to start filling a cavity, or this would be another example, if they were to start filling a cavity without any Novocaine, that's nerve pain. So if you kind of think of that nerve pain out in the body, you can imagine how painful shingles is. As far as what we do for management for shingles, most of it's aimed at pain management because it is self-limiting. Most cases are not severe. Most cases are fairly mild, although they do hurt. For a mild case, it stays localized to the skin, so they just have skin damage, and they might have some lasting nerve damage that takes a while to heal. That's still considered very minor. Although the patient's not going to call it minor, they're going to call it the worst thing they've ever experienced. In more severe cases, though, it can actually travel inward and start affecting organs. So for the less severe, where it's just on the skin, just kind of in the nerve pain, we use a topical form of an antiviral agent. But then for the more severe forms, they're going to need the IV forms. And that'll be a concept I want you to remember. For less severe viral and fungal infections, topical types of medications will be used, but then for the more severe, you're going to need some sort of an intravenous form. And we now actually have a vaccine against shingles as well that I think they encourage everybody over the age of 55 or 60, somewhere in there, to get vaccinated. I fell into the age category where I was too old to get the chicken pox and I'm too young to get the shingles, so I'm just kind of SOL on both ends. Anyway, digressing. As far as how these drugs work, they're going to work somehow by blocking the activity of the enzymes which stimulate the synthesis of new viruses. What that means is they impair viral replication, which decreases the viral concentration. By decreasing that concentration, it can help the immune system to go in and do what the immune system does best, which is eradicate the virus or get rid of the virus. If it can't completely get rid of the virus, it can at least put it into a dormant phase so the patient isn't having clinical manifestations. So for like herpes, we know we're not going to eradicate that, but we can put it to a dormant phase where it's just there but not actively causing problems. Others like influenza and shingles, shingles we don't eradicate, but we put it into more of a permanent or a long-term dormant phase, but then like influenza, we could eradicate that. For those viruses that we can't completely get rid of, so say shingles, or, well, not so much shingles, a better example would be, say, herpes, they might need just a daily dose of some sort of antiviral to keep that virus within dormancy, otherwise it'll start to flare up again. The indications are listed there. We've talked about herpes. We didn't talk a lot about influenza. We'll talk about that with the drugs which treat it. Same thing with RSV, can be used with an antiviral for children. And then CMV is that cytomegalovirus for patients who are HIV positive will develop those. For adverse effects, we're going to cover those with each individual drug, so we're not going to worry about it too much right now. But what I want you to know, because these agents typically kill, like they kill viruses, but then they also tend to kill a lot of cells, they can have some potentially widespread side effects that we'll touch in a few minutes. With the interactions, what I want you to remember right now in this concept that I do want you to know is when they're applied topically for like the less severe infections, there's really going to be very few interactions and there's going to be few side effects. The side effects and interactions are going to increase when they're using either an oral route for maintenance therapy or an IV route for more severe cases. So when they're just using topically, there's probably not going to be a lot of side effects and there's not going to be a lot of interactions. We worry more when they get absorbed systemically about the interactions and the side effects. So the first drug of the day is going to be amantadine. And amantadine is indicated for influenza A. and for Parkinson's disease, which is kind of weird. But for influenza A, it can be used either prophylactically or therapeutically. Prophylactically meaning it can prevent the virus, or therapeutically meaning it can treat once the patients become positive for influenza. The tricky thing with amantadine is that it only works when the type of flu, active flu, like there's only a couple strains of the active influenza A it treats. So therefore the rules and regulations for using this medication change year to year based on which strains of influenza the CDC thinks are going to be active. So like this last year, amantadine really wasn't recommended because it wasn't found that amantadine treated most of the active influenza strains from last year. Now, as you know, the vaccine for influenza is based off what they think will work. And this year they kind of missed that mark, so a lot of people who got vaccinated still came down with influenza A. The same thing here. Sometimes, even though it wasn't necessarily recommended to use amantadine this year, sometimes physicians will still use it in certain patients, particularly those who are immunocompromised, because we don't really know if the CDC is right. Most of the time they are, but sometimes it's not. So they'll still use this drug because it's fairly well tolerated to help preserve life in the patients who, like our chemotherapeutic patients, immunosuppressed patients, patients with AIDS. Those types of patients, it's worth the risk. Even though it might not be effective, it's probably not going to hurt them, and it could help. So that's just one of the goofy things with amantadine. Sometimes it works and sometimes it doesn't. The other use for amantadine that we see it used for is Parkinson's disease, and how it helps patients with Parkinson's is it increases the release of dopamine from nerve terminals. Now, eventually the nerve terminals run out of dopamine, so it only works for a short amount of time, and it's only used in the early stages of Parkinson's disease. But that's one other time when you might see amantadine used that's not virally related at all. As far as contraindications, the only big ones would be if somebody was allergic to it. Otherwise, it's not recommended in women who are breastfeeding and children who are younger than 1 year of age. The adverse effects for amantadine, because it's working on dopamine, it can cause some CNS stuff, so insomnia, nervousness, lightheadedness, anorexia, and then it can also cause some anticholinergic effects. And remember, anticholinergic is kind of the anti-parasympathetic, so anti-rest and digest, which means it dries everything up. So it could cause dry mouth, constipation, blurred vision from the dry eye. It can cause those dry effects as well. Some of the interactions, the first one's an anticholinergic medication. So if somebody's taking anticholinergic medication, say for asthma, it'll help potentiate the anticholinergic effects of amantadine as well. So they're just going to have more pronounced dry mouth, more pronounced urinary retention, more pronounced blurry vision from a dry eye, just more pronounced anticholinergic effects. The other medication that this interacts with are CNS stimulants because amantadine can stimulate a little bit. If somebody's on a CNS stimulant for, say, ADHD, it can potentiate the CNS stimulation, which essentially just results in more insomnia. And this is a medication which is available by the oral route only, so there's no cream for amantadine, it's just via the oral route. And again, the only virus it's used to treat is influenza, and it's only used to treat influenza during certain years when they think the right strain will match this medication. The next drug we have to talk about is acyclovir, and this is going to be one of the more common ones you see. And something that I want you guys to make note in is anytime you see this Clovir in a name, the C-L-O-V-I-R in the brand name, it's most likely an antiviral of some sort. And it's most likely an antiviral to treat herpes. So that's just my little tip, is to remember this one. So the indications for this drug, it's going to treat actually both strains of HSV, both 1 and 2. So some people will use it if they have really bad cold sores. Otherwise, it's most commonly used for HSV 2. And again, they'll use a low dose to help prevent the attack and a higher dose to treat the outbreaks. So they might be on a low dose daily, and then when they have an outbreak, they'll have instructions from their doctor to double the dose. And what it does, it's taken in the oral form to help prevent an outbreak, but then it also comes in a topical form to help reduce the pain associated with the lesion. So they'll actually rub it on the lesions or apply it to the lesions to help reduce some of the pain associated with it as well. In addition to HSV, it can also be used for shingles and chickenpox. And what it does is it simply suppresses the replication of the virus, so that it slows down the replication, and then it puts it back into a dormant. Now, acyclovir is fairly well tolerated, which is one of the reasons why it's our common medication. As far as side effects, when taken via the oral route, it's only going to cause maybe some nausea, diarrhea, headache, not a whole lot. It's very well tolerated. One thing that people might notice when they're applying the cream to a lesion is that it'll burn for a few seconds before it feels better. So sometimes there's some burning, but only when applied topically. The routes for this are going to be oral, and that's going to be used more on a daily basis to help prevent an attack, or a higher dose might also be used to push an attack back into a relapse mode. Topical example of when that might be used would be to make the lesions feel better, reduce the pain associated with them, and that could be HSV or it could be the shingles as well. There's acyclovir for shingles, so it could also be used to reduce some of the pain associated with shingles. And then also in an IV form for really severe cases of shingles is when we would see it used intravenously. The next non-HIV antiviral that we have to talk about is Tamiflu. And this one's kind of an easy one to remember because when you see the Tamiflu, it ends in flu, so just connect that to the fact that it's used to treat flu, is how I remember what Tamiflu does. This is a little bit newer medication than amantadine, and its indications are both for influenza A and B, whereas amantadine was only good for influenza A and only certain strains of influenza A. This one tends to be a little bit more broad, so they'll use it a little bit more frequently. They can use it both prophylactically to prevent or therapeutically to treat, but if they're using it therapeutically, it's only going to reduce the duration of the virus, and it must be started within 48 hours of the virus of the onset of symptoms. So from 48 hours to the time they start feeling sick is when they need to get on it. And it's normally reserved for immunocompromised patients. Because it is a medication, there are some side effects associated, although they're minor, and it is relatively expensive. And people who are, quote unquote, young and healthy will typically they just give them fluids, if anything, and then tell them to go home and rest. The only patients who really get treated with antivirals for the flu are those who are immunocompromised. So again, your patients who are on chemotherapy, have an organ transplant, are HIV positive, those types of patients will get it. I think that's about all I have to say about Tamiflu. There's nothing really exciting about it. Side effects are mostly nausea and vomiting. There's not a lot associated with it. If the nausea and vomiting get too bad, then it can cause dehydration, which would then require IV fluids. But again, it's not a bad medication. It's newer. Seems to be working okay for us. The next section that we need to talk about are going to be the HIV and actual AIDS patients. And just, again, a quick pathophys, because this is certainly a disease that you can spend a year speaking about. It's really, really complex, and it's really a sad disease for somebody to develop. With HIV is, though, patients, when they become HIV positive, they always start off as HIV, and then as the disease progresses, then they become an AIDS patient. So when they're HIV positive, they'll stay just HIV positive for so long, and then they get diagnosed with AIDS. But it will always progress forward to the AIDS diagnosis. And what it is it's a retrovirus, so it's an RNA virus. And how it works is it gets into the enzyme, the reverse transcriptase, during the replication process of natural RNA. Now this is a little bit backwards because typically RNA comes from DNA, but what it does is it kind of reverses that process, so then DNA starts coming from this infected RNA. Now, when this process gets flipped around and goes backwards, there's a really high rate of errors. And that high rate of errors can, one, cause cancer, which would be like the Kaposi's sarcoma you might have heard about with HIV patients. But it can cause cancer, and it also causes these viruses to have a really high rate of mutation. Now, the fact that these viruses have a high rate of mutation makes this virus very difficult to treat. So for pathophys, you'll learn more about that. For pharmacology, I want you to understand that it's kind of a backwards process. RNA is going to come, or DNA is going to come from RNA. And the fact that it's backwards means it's going to have that high rate of errors, and that's going to result in quick mutations. It's this fast mutation of the virus that's made it really one of the things that's made it really difficult to treat, because we'll find a drug that works well for a patient, we'll put them on that drug, and it works until the virus mutates to that drug, and then we need to find a new medication. And unfortunately, eventually we run out of medications and we don't have anything that's really good to treat this because it's mutated to all our medications. And then if, heaven forbid, the person was to pass that mutated virus to another person, as soon as that person gets diagnosed with HIV, they're already immune to all of our first-line antiviral agents, and we just don't have anything really good to treat them with. So it's the fact that it has this high rate of mutation that makes it really difficult to treat. As far as the replication goes, is it maps the DNA for the cell, and it maps that DNA for the cells with the virus in it. So the virus becomes very widespread, and it creates what we call a provirus, and that's just a DNA for the body with that virus built into it. Now, it will go into a dormant phase, which can last up to 10 years, but then eventually it will become active, and the patient will start to see clinical manifestations from it. The person doesn't actually die of this virus. What this virus does is it wipes out your immune system, and then the patient dies of an opportunistic infection. So that's an infection that comes in, and the body normally would be able to take care of it with no problem, but because the immune system is so compromised, they die from like the simple head cold. From really simple infections is typically what is the end killer of this disease. There's a couple different ways it's transmitted. I'm sure everybody's been told that it's transmitted sexually, which it is, and it's transmitted, how this works is the virus itself is actually present in all body fluids, but the only fluids which have a high enough concentration of the virus in it to transmit it are going to be genital fluids and blood. So if you were to, say, kiss somebody who's HIV positive, you wouldn't get the disease because there's not a high enough concentration in our oral secretions to transmit the disease. You must come in contact with either the genital area or the blood in order to have that contamination. And this is why they say it's okay, like, you don't have to put these people, well, you put them in total isolation for their safety, but this is why, like, you're not going to catch AIDS from like eating at the same restaurant as somebody who has AIDS. So that's how it's transmitted. It must come in contact with blood or some sort of genital fluid. The next way it can be transmitted would be via blood transfusions. Now this is very, very rare nowadays because we test all donated blood for HIV. However, people who received a transfusion prior to 1985, there was a risk of HIV associated with it because they didn't really know about the disease back then, and they didn't have a way to really test blood for it. So there are cases of people dying from HIV and AIDS in the late 80s, early 90s from getting it via a blood transfusion. Now that would be very rare. It could happen, but it would just be very rare. The third way your book lists is IV drug use, and it's not the drug itself that causes HIV, it's the sharing of needles. So I just want to clarify that it's not the drugs that they're taking that cause it, it's the fact that they're sharing needles. And if they're sharing needles, then there's that risk that they're passing HIV among each other. And there is a very high risk of HIV and AIDS among people who admit to using IV drugs, and that's why. That is also why some places will actually provide clean needles to drug users and they provide these needles knowing that's what they're being used for. It's an ethical dilemma because they say, well, it's better to give them drug needles, although we're enabling them to use drugs, at least they're doing it in a more safe way, and we're doing a greater good by preventing the transmission of diseases. And then other people say you're hurting them by giving them access, I guess, to clean IVs. So just know that is something that every once in a while will flare up in the media, and you'll talk about it throughout nursing school and throughout your degrees, whether or not that's ethical to give people you know are using needles for drug use to give them that, or if it's better to condone it and pretend they're not doing it and then they get AIDS. So I don't really know the answer there. I just want you guys to be aware that is a controversial debate that you guys will hear throughout your career. Anyway, moving on, the next and final way that we're going to talk about HIV being transmitted is via childbirth. Perinatal transfer from mother to child. Without treatment, about 30% of mothers would pass the virus on to their child. And this can be done either in utero or at the time of birth, as the child comes through the birth canal. How we treat mothers now, and actually with the treatment of antivirals, it's a less than 10% chance that child has of getting the HIV positive, which is really phenomenal. So antiviral agents have helped decrease the transfer of AIDS from mother to child quite well. And what we do is we'll treat the mother with an antiviral, and Zyvodine is the one we use for this. We'll treat them during their pregnancy. And then the child will get treatment for, I believe it's 6 weeks after birth, of Zyvodine as well, to help kill any virus while it's still young and killable in the child. And most of those children, in fact, I would wager, your book says less than 10%, I would wager it might even be lower than that. So that's really, really exciting for the medical community that we're doing that. Now the next thing that we worry about, though, is the virus can be spread via breast milk. And there are, if you follow organizations that provide care to patients who are HIV in Africa, there's a couple different foundations that do this. They will provide breast milk so mothers aren't tempted to breastfeed their child and prevent the disease transmission that way. But unfortunately, what sometimes happens is parents will sell the breast milk for money, or the formula for money, excuse me, and then they'll continue to breastfeed their child. So it takes a lot of education, and I would like to think it's because they don't know that they're hurting their child, but it takes a lot of education if you are ever to go into that situation, that you can't, you really shouldn't breastfeed just because the risk of HIV is so high, and you don't want to pass that along to children. But this is a pretty significant epidemic in different parts of the world, and it's certainly still prevalent in America. You would be surprised, even here in Bismarck, North Dakota. It's not frequent, but it's also not infrequent for us to get patients who are HIV positive in the hospital. And of course that comes through their medical records so that we know, so we can take extra caution, although you should treat everybody as if they're HIV positive and not be contaminating yourself or them. You would be surprised how many people come through the hospital that are HIV positive, and it's a really sad, sad disease. I don't know if you remember back to the summer of 2014, I think it was, just a year ago, there was that plane that was shot down in Russia. And the plane that was shot down actually had some of the people who were working on a cure for HIV were within it. So when the plane was shot down, those people went missing. Much of the research that had been done on HIV and AIDS was also lost because we lost some of the brilliant mindsets that were actually creating our cures as well. So that's going to set us back a little ways as well. It doesn't matter what your views are on this disease. It's a very, very sad thing, and it's something that as a healthcare provider, you're most likely, I never thought I was going to have to work with this going into a surgical area working with neuro patients, but you're going to end up working with it no matter where you go, unfortunately. Hopefully not much, but be there. So, digressing. As far as staging the disease, it goes from stage 1 to 4. Stage 1 is when the patient first catches the virus, and at this point they're going to be asymptomatic. This lasts a couple weeks to a couple months of the disease, and during this first stage, they have a very low count in their system, but there is still a possibility that virus could be passed on. And this is probably where most people do pass the virus on because they don't know they're positive, and then they continue to engage in risky behaviors, and the disease can sometimes be passed on without knowing it. During stage 1, really the only symptoms they might have is they might notice a few swollen lymph nodes. Otherwise, they feel pretty good, and it's not enough to really cause them to be concerned. And then eventually they move to stage 2. And stage 2 is where they start having early general symptoms of the disease. So they're going to now start noticing some swollen and painful lymph nodes, which would be the lymphadenopathy. They'll probably also have a fever and just not quite feel well, kind of feel like they're coming down with the flu that doesn't go away. They might develop a rash, they might develop a sore throat, they might have sore night sweats, and they'll be more prone to developing thrush and shingles. Now, stage 2 is typically where they know something's wrong and they go to the doctor and they start getting worked up and then they get diagnosed. So stage 2 is typically where they start going on antiviral medication, because as soon as they're diagnosed, they start their medication to help prevent the disease from progressing. For that reason, people can stay in this stage 2 for quite a while. They can stay into it for up to 10 years, but eventually the virus does mutate and they progress to stage 3. Stage 3 is where we say they have moderate symptoms, and this is where they start to look different from other people. They tend to be very thin and anorexic looking, very gaunt looking. They will normally have chronic diarrhea, a constant fever, and stage 3 is where they start catching what we call the opportunistic infections that come in when the immune system is so compromised they can't fight off what other people just fight off, no big deal. So that starts at stage 3. And stage 3 is where they're going to start probably seeing more hospitalizations. They're still going to be on their antiviral agents, but truly at stage 3 we're starting to lose the battle. And then stage 4 is where they have their severe symptoms, and this is often where they lead to death, although death can occur in stage 3 if they catch the right infection. And this is where the severe opportunistic infections occur, and this could be anything from pneumonia to a head cold to a UTI, Kaposi sarcoma, CMV. All those are what we call opportunistic infections, and they come in and the patient eventually does perish. Box 40.2 on page 662 of your textbook outlines a few more of those opportunistic diseases or infections. So if you don't know what they are, or you haven't been exposed to this information, you might find it beneficial just to look there and a little bit. So moving on to the drugs which are used to treat HIV infections. The mechanism of action, they're all a little bit different, so we will talk about the true mechanism of action when we talk about each drug individually. And I think it's on page, 665, maybe they list all the different antivirals, and there's probably 20 listed in your book, if not more. We're only going to talk about 4 of them, I believe, 4 or 5 of them. So you guys can all send me a little thank you card that I'm not making you memorize all of them. And the reason why I'm not is most of you won't work with these medications unless you decide to specialize in here. So we're just going to hit the kind of big concepts and talk about the big ones that when you hear the name, I want you to think antiviral for HIV. So what we call this treatment is highly active antiretroviral therapy. And an antiretroviral is simply an antiviral used for HIV. Antiretroviral therapy, so HAART therapy for short. Patients who are undergoing HAART therapy are going to be on at least 3 different medications. Sometimes the medications will come within the same category, and sometimes we'll jump to a couple different categories to try to fight the infection a little bit better. So a couple examples I have there for you would be like 3 NRTIs, which stands for, I gotta look at it or I will butcher it. It stands for the nucleoside reverse transcriptase inhibitor. Or they might be on 2 of those, the nucleoside reverse transcriptase inhibitor and a protease inhibitor. Or they might be on a NRTI plus an NNRTI, which is just a non-nucleoside reverse transcriptase inhibitor, with an additional protease inhibitor, and they might have a anti-fuson inserted in there as well. So they'll be on a very complex medication regimen. Why we do that is it's more effective at slowing down the disease process because these drugs work in a little bit different mechanism of action, so they complement each other. We're using them synergistically. So it's going to be more effective at slowing it down. Also, because we're hitting them with a couple different types of medications, it's going to be harder for that virus to mutate. And the fact that the virus isn't mutating as easy is what keeps the patient, within those early stages longer. However, because it's a multi-drug therapy, it's very complex for patients to follow. And again, we're not going to get into the specific details for all these drugs, but what I want you to take away from heart therapy is that these drugs are very complex. It's a multiple medication thing a day. This isn't a med that they take once in the morning and they're done. They might take one medication at 8, 3 at 10, 1 at noon, 4 at 3, and then another 6 at night. And it's not unusual for them to be on that many medications. In addition to the vast number of medications they're on, some of those drugs need to be taken with food, some need to be on an empty stomach, some are incompatible with each other, so you have to make sure there's so many hours between them. Some don't interact well with any other medication you're on either, so then it has to be even more separate. It makes it very difficult for these patients to keep it straight. Keep in mind, most people who come down with HIV don't have a medical background, so they're coming in with no information on how drugs work, and now suddenly they have to deal with the idea that they have this life-altering disease, plus they're trying to learn these medications. So make sure you keep that kind of in the forefront, and be compassionate. The other thing with these is that they're very expensive, and a lot of patients, unfortunately, a lot of patients who have AIDS don't have the means to pay for the therapy, and sometimes they don't get the drugs that they need to preserve their life, and then that would obviously increase the disease progression as well. Anyway, our goal for heart therapy is a viral load of less than 50 copies per milliliter, and that'd be 50 copies of the virus per milliliter of blood, which is still a lot, but less than that helps prevent the disease from progressing, and it helps prevent the immune system from completely collapsing on them. We also want to slow the disease progression and then prevent the onset of opportunistic infection. So there's lots of education that goes on as far as what they need to avoid: crowds, sick people, hospitals, good hand hygiene, even stuff as simple as thoroughly cooking all food so you don't get any sort of microbe on your vegetables that come from a garden. For them to eat a fresh vegetable, that would be a huge no-no. All their food should be boiled, cooked. They can't eat anything raw because of the risk of infection. So it becomes pretty intensive for them to try to deal with. The indications for heart therapy include an active HIV infection. Otherwise, it can be used prophylactically in people who have been exposed. And this would be like a healthcare worker if they get poked by a needle that the patient's known to have HIV. Or it could be in an infant whose mother is HIV positive. So we do use it prophylactically sometimes as well. We'll cover the adverse effects and the interactions with the medications. And we're not, like I said, we're not going into huge detail on these. So if we don't cover it in the outline, it's not something I terribly expect you to know. We're just getting kind of the big outline of what these medications do. And then you'll learn more about them through your community classes. Or again, if you decide to specialize. What I'm teaching you now is just what you'll need to know for like licensure and for being an educated person. So the first one we're going to talk about is Fuson. Fuson is a fuse inhibitor, and it's easy to remember because the fuse and Fuson, and then it's a fuse inhibitor. So if you think back to how these medications work, the virus fuses with its host, and this fuse inhibitor just prevents that fuse from happening. So if they can't fuse, then they can't replicate. So it slows down disease progression just a little bit. Fuson is only a subcutaneous injection, so therefore your major side effect is going to come from injection site pain. Now the type of injection it is subcutaneous. It tends to be very hard on the tissue into which you inject it in, that fatty tissue. For that reason, it's going to be very painful. It will cause some itching, some redness, It can cause cellulitis, abscesses, and infections as well. And obviously, we really don't want a patient who's taking Fuson to get an infection from their medication because they're going to be prone to infections anyway. And this drug, just piercing the skin, increases the risk of infection. Plus, it tends to kill off some of those cells right there because it's very toxic to those cells. And that increases the risk of infection. So you just watch the injection site and you educate the patient to watch for excessive redness, pain. If it gets a funny odor at all, the quicker we can treat it, the better off they are. Other adverse effects are fairly mild and it's well tolerated, some nausea, diarrhea, and some fatigue. Some of this, it's hard to know if it comes exactly from the medication or from the disease, because if you think back to the disease clinical manifestations, like the diarrhea and fatigue are both clinical manifestations of the disease as well. So again, you don't really know, is it the drug or is it the disease or is it a combo of the two? The next one is Soolantra. Soolantra is an entry inhibitor, and I have on there just a little easy way to remember that with the Soolantra, entry inhibitor kind of thing. Might make it easier to remember. What it blocks is it blocks this enzyme called CCR5, and what that does is reduces the virus's load in the body, plus it also increases the T cell production. If you think back to like an anatomy and physiology class or a pathophys class, you probably learned about how the immune system naturally functions, and it has these T cells which go out and they protect your body. So by increasing the T cell production, it can actually give the immune system a little bit of a boost. It's a new medication. It was just approved in 2007. So we don't know a lot about like the long-term side effects yet, but so far it seems to be doing okay out in the public. It's really hard to do long-term studies with these drugs because most of the patients who are on them don't live for a lot of years. So we don't have a lot of good data on that either. But one side effect we do know that happens is hepatotoxicity. So it's really hard on the liver. For that reason, we encourage them to not use other drugs which are hepatotoxic like Tylenol. We also encourage them not to drink alcohol to be kind of safe in that manner as well. Now, this is a medication which is typically administered fairly late in the treatment stage. We have, and I forgot to tell you guys about this earlier, but these patients are going to be classified as treatment naive or treatment experienced. Treatment naive patients are going to be when they first are diagnosed with the disease. And as a rule of thumb, when they're first diagnosed with the disease, they respond a little bit better to our medications because hopefully the virus hasn't mutated yet. As they are on a medication, then their virus is going to start mutating. So then we call them a treatment experienced patient. And that simply means that their virus has mutated and become immune to a lot of our different drugs, and it's more difficult to treat them. Now, if they happen to catch the disease from somebody who is treatment experienced, then they start off with already that strike against them and the fact that the virus that they caught is probably more sophisticated. So there is that risk as well, but as a rule of thumb, when they're first diagnosed, it's a little bit easier for them to treat. So anyway, going back to Soolantra, this is a treatment experienced patient, so somebody who's in the late stages of disease. And one of the interactions, or two of the interactions with this drugs are antiviral and antibiotic agents. As far as why this might be a problem for these patients is they're probably going to be starting to develop opportunistic infections. And now if they're on a medication which interacts with their antibiotics and antifungals, it's going to make it extremely hard to control their opportunistic diseases. So an example of an opportunistic infection might be thrush. They get a horrible case of thrush in their mouth. So we give them an antiviral. Well, the Soolantra makes that antifungal agent, it makes it not work. So now they don't have anything to treat that thrush. So now they just have a really itchy mouth. Or they could catch an infection, like a bacterial infection. Soolantra has this wicked habit of either increasing antibiotics toxicity or decreasing its effectiveness. So either way, it takes a very experienced doctor who's had lots of extra training in this disease process and these medications to try to balance the drugs so that they don't cause more harm than good. But it does become an issue of, well, is it beneficial for them to be on this medication? or not. If we're running the risk of ending their life prematurely with a drug toxicity, then we have to start considering what's best for the patient. And lots of education with the patient as well. This is the drugs we have to offer you. Unfortunately, these are the side effects. This could happen. You know, they get a say in it too. What do you want to do as well? So you can give them advice, and you obviously the healthcare team is going to give advice, but then ultimately it's their choice as to what they want to do or not do. Now the next one tends to be the most common one, and that's Zivudine. Zivudine is an old medication. It's been around for forever. And how this works, it's a nucleoside reverse transcriptase inhibitor. So it blocks the activity of the enzyme reverse transcriptase, which slows down the transmission of that viral RNA and prevents it from becoming a prodrug. So it simply slows down the transmission of the viral RNA. And I don't know why I didn't get that highlighted for you guys. I apologize there. But it slows down that transmission is what you need to write down by B. This is the oldest HIV medication on the market. It was the first one introduced, and when they first introduced it, it worked pretty good. And then the virus mutated, and now it only works in patients who are very treatment naive, but we still commonly use it for pregnant patients and neonatal patients. And the reason why we know we can use it in pregnant patients is we know it's safe for the developing baby. We also know it's relatively safe for the baby during that neonatal period as well. So we still commonly use it in those two categories, and then in a very treatment-naive patient that virus hasn't started to mutate either. The virus mutates very quickly to this drug, which is a huge drawback for it. It can be given either orally or injectably. And the side effects here, the big one is bone marrow suppression, which then increases the risk of both infection and anemia. Which are two things we don't want to do with HIV patients because they're already at a risk of infection, and we just never want to make anybody anemic because that contributes to like the fatigue, shortness of breath, energy levels that patients have as well. So that's one of the big drawbacks to Zivudine. As far as interactions go, there's many. I'm not going to have you guys learn about them right now because some of the stuff it interacts with we haven't covered yet in class. And that's kind of probably beyond what you need to know to just be a safe general practitioner. So if you want to be a superstar and learn them, you can, but I'm not going to require you learn them right this minute either. The next one is a combination drug, and this is actually one that your book did not profile, but it's still used fairly commonly, and although it's not a drug profile in your book talks about it quite a bit throughout the chapter. So I am going to go ahead and include it, and that's Kaletra. Lopinavir with ritonavir. And these are two protease inhibitors, so how they work is they block the viral enzyme protease, and protease is responsible for the final assembly of the virons. So by stopping that final assembly of the virons, it helps prevent the maturation of the virus cells, because at the stage where this protease interacts with the virons, those virons are not completely mature yet. So it kind of keeps them in that immature mode, if you want to think about it in that aspect. And when the virons are not mature, they're not infectious. So by keeping them in an immature mode, it helps prevent the spread and the development of the disease. Now how this works, it's a combination of two protease inhibitors. The ritonavir prevents the breakdown of the lopinavir, which allows for least frequent dosing intervals, and of the two PIs, we want the lopinavir higher than the higher. And the reason why we want the lopinavir higher is it's the protease inhibitor, which actually prevents the breakdown of prevents the maturation of the virus. So the ritonavir is just there to help prevent the breakdown of the lopinavir. That helps keeps a higher system in the body, and then in turn that helps prevent the maturation of the virus. This is one drug that must be taken on an empty stomach, and it's still, I think, a twice-a-day medication, so they still have to find an empty stomach at least twice a day. Some of the side effects, they're not terrible actually. Diarrhea, headache, nausea, vomiting can cause a spike in blood sugar, and then if they're using it long-term, it can cause the fat to redistribute, which is a lipodystrophy, And what happens is these patients tend to lose some of the fullness in their cheeks, so their face becomes really thin, and that fat seems to locate to the back of the neck. So they'll develop kind of a hard lump on the back of the neck. And it just adds to the altered body image that these patients tend to already be experiencing. So that's a drawback to the medication. The other big side effect is pancreatitis, so they need to be careful. If they start having pancreatitis, that's something that they'll get hospitalized for. It's very painful. It's not deadly, but it's very painful. They can't eat for a while. Certainly not much fun. And that concludes the chapter on the antivirals. Now we're going to talk just a few minutes again about the antifungals. Our objectives are also online, but we're going to talk about, do I have 3 or 4 different antifungal drugs for you guys to learn? But identify what the various antifungal agents are, talk about its mechanism of action, and then just kind of a nursing care plan as to what we're going to be watching for and why we care about these. This is a class of drugs which we're not going to use a whole lot because fungal infections tend to be relatively rare in America. So again, it's not something you're going to work a lot with. There's just a couple core concepts that I want to make sure you understand to prepare you in case you would decide to specialize in a fungal clinic, which if you're going to specialize in a fungal clinic, you might have to go elsewhere in the nation because I don't know that we have one in Bismarck. Digressing though, fungal infection, what exactly is it? Well, fungi are simply microorganisms which require an external source of carbon, and then it forms a plant structure. We have yeast and we have mold and then we have mushrooms, but most of us don't have mushrooms growing in our body. So most of our fungal infections arise from either a yeast or a mold. And yeast are simply single-celled fungi and they reproduce by budding, which means one single cell just kind of gets bigger and then it breaks off into a daughter cell, and then that daughter cell gets bigger and then breaks off into another daughter cell. Yeast is actually used in making bread and alcoholic beverages, if you did not already know that. It is also a part of your natural flora, and you need it in your body in order to maintain everything. But sometimes when, like we talked about this with antibiotics, when you use an antibiotic and it wipes out all your good bacteria, it allows the yeast to overgrow and then you end up with what we call a yeast infection. There's other ways to cause yeast infections, but that's what it is, are those little single-celled microorganisms going crazy on your body. Now, mold is a little bit more scary of an issue, and there are cases of people having mold in their body, but mold is going to be a multicellular fungi, and it's going to be a lot more difficult to treat. It's going to be a lot more severe of a disease or of an infection to treat. Yeast is fairly benign in the fact that it might be really itchy and obnoxious, but it's not really deadly. Mold becomes deadly. And then there's mushrooms, but like I said, most of the time we don't have little mushrooms growing in our body. Although, since we're talking about AIDS, I can share this story about a case study I read a couple years ago about a couple guys that were both HIV positive, and they went camping in the woods, and they decided they were going to go scavenge for mushrooms, which was a really terrible idea, but they did it anyways. And the one guy that was preparing it is the one this happened to, and I think that while he was, anyways, sticking with my story, he prepared the food, they ate, it was great. They went about their life, and a couple weeks or months later, I forget, he started noticing that he had really bad sinus infections. So HIV positive, went to the doctor right away, got on some sort of antibiotic, antiviral thing to try to clear it up. Didn't really clear up, didn't clear up. And finally they did, I forget what test they did. They did something, they looked up his nose, and from preparing the food, he must have touched his face or breathed in some of those pores, but he actually had mushrooms growing in his sinuses. So I'm not going to say you won't never ever get mushrooms places where they shouldn't be, but it's very rare. Obviously not something we see all the time, but there's proof it can happen. As far as what fungal do, there's actually over 200,000 different varieties in the world, but only approximately 50 of them actually cause a disease, so it's relatively rare. They like to grow where it's moist, and they tend to grow most via inhalation, so like with your equipment to take in and like your asthma equipment for a corticosteroid. If you don't clean that up, fungus can grow in there, and then as you breathe it in, your lungs are a very moist, dark, damp place that likes to grow down there. So you could get a fungal infection in your lungs. More likely to happen if you're immunocompromised, but it could happen anyways. Otherwise, exposure is typically either by inhaling, so through like an inhaler, or it could just be in the air, or by handling contaminated soil. So this is a reason why it's a good idea to always wash your hands after playing in the garden, because sometimes fungus can be transmitted by like bird droppings, cat droppings, stuff you can't necessarily see. So don't touch your nose while you're out gardening, and then wash your hands right away when you come in. Also, don't put your nose down into the dirt and start sniffing, because you don't want to sniff something up either. Overgrowth typically occurs in dark, damp areas, typically the mouth or skin folds or the vagina. And fungus in of itself is a very slow growing organism. So it takes like many months to see symptoms. It can take up to a couple months to see symptoms of this. Just keep in mind, fungal infections are slow growing and it takes a long time to clear them up as well. As far as what a fungal infection is, we call it mycosis, and simply a fungal infection. Pathological fungi would be the 50 fungal varieties that actually create the mycosis. The other 100,900, no, I don't even want to do the math. The other several of them don't cause a mycosis. They're pretty benign. Symptom types include systemic, cutaneous, subcutaneous, and superficial. Your systemic are going to be the most severe, and they're going to affect the internal organs, so mostly the brains, the lungs, and the GI system. Cutaneous, subcutaneous, and superficial are all going to occur somewhere on the skin, somewhere in the layers of the skin. Most commonly, they occur superficially, which would be like the scalp, skin, nails, and mucous membranes. An example might be like athlete's foot, or kind of the gross yellow looking nails that sometimes people get. Or ringworm would be another one, superficial infection. People who are immunocompromised are going to be at the highest risk of developing a mycosis, so those would again be the patients we've talked about with their organ transplants. Autoimmune disorders, and again, it's not the disorder itself that causes them to be immunosuppressed, it's the medications that they're on to control the disease that causes them to be immunosuppressed. And then there's certain medications that can also cause patients to be immunosuppressed, including antibiotics. And we've talked about that, how that helps fungus kind of grow. So how we treat it are just antifungal agents. And on a general note, the mechanism of action is going to depend on the different drug that you're using. But it's going to work in one of three ways. It's either going to disrupt the critical cellular metabolic pathways of the fungal cell, or it's going to prevent fungus from reproducing. If they can't reproduce, they can't create a little colony. Or it's going to bind to a sterol in the cell membrane of the fungi. Fungi have a sterol, and it's called I gotta see it or I'm gonna mispronounce it. I'll probably mispronounce it anyways. Estradiol, estro something or another. It's related to cholesterol. In humans, we have cholesterol. It's fungus's version of cholesterol, essentially. What happens when a drug binds to that sterol, though, is it allows potassium and magnesium ions to leak out. And then this alters the cellular metabolism and then eventually kills the cell. Indications for your antifungal agents include topical fungal infections or a systemic fungal infection. There's really no off-label use for them. It's just for a fungal infection. And some are used specifically for topical, some are used specifically for systemic, and some can be used for both in different routes. Like a topical is almost always treated with with a topical agent, so a cream, where systemic will be treated most of the time with an IV or an oral type medication. Contraindications include liver failure and kidney failure. Especially if it's a systemic fungal infection, they might still get the antifungal agent because without it they'll die, but just know that it's really hard on both the liver and the kidney. So the first drug we're going to talk about is amphotericin, also known as amphotericin because of all its side effects. How amphotericin works is it's got this mechanism of action where it binds to the estrosterols, or the sterol in the fungal membrane. which again is the fungus's version of cholesterol, and it allows those ions to leak out, and then the cell dies. As far as, and I had to laugh because your book says it doesn't kill human cells, it just kills the kidney cells. We'll talk about that in a few minutes. Although it doesn't necessarily kill the human cells, it's certainly not easy on the human cells either, so don't let your book fool you into thinking that's a safe medication either. Indications for this: if somebody's on amphotericin, they have got a wicked fungal infection. It's almost completely reserved for severe systemic fungal infections. And I have the different types of fungal infections or fungus that can cause the infections there. Don't get hung up on learning them. If you do, great. If you don't worry about it. Know that the type of fungal infections that this guy treats are going to be ones that are within the lung, the heart, the brain, the GI system. Fungal infections that are inside the body is when you're going to need to use amphotericin. You're probably, although you could use amphotericin for a superficial infection, you're probably not going to. It's mostly used for those really severe, so like fungal endocarditis would be a fungus on the heart. Gungal, I think that was supposed to be fungal septicemia, would be patients who are becoming septic from a fungal infection. Those are the times when you're going to use amphotericin here. Now, as far as why we call amphotericin or why it's terrible are its side effects. The first one is a cardiac dysrhythmia. And the cardiac dysrhythmia is typically caused when the medication is infused too fast. So for that reason, you don't have to memorize how fast to infuse it, but for that reason, this medication, once given IV, it just barely drips into the patient. This is also why it's important to monitor vital signs while the medication's being infused. Because if you infuse it too fast, it'll start causing cardiac dysrhythmias, the patient becomes hypotensive, and they can have a cardiac arrest, and people can die from this medication getting infused too fast. So we introduce it very slowly into the body. Otherwise, it causes a cardiac dysrhythmia. The other thing this medication does cardiac-wise is it depletes the body's source of potassium. And if you don't have enough potassium, that can also induce a cardiac dysrhythmia. So it's not very friendly to the heart at all. The next one is neurotoxicity, and that's manifest as ringing in the ears, visual disturbances, numbness and tingling to hands and feet, and convulsions or seizures. Now the neurotoxicity, there's not a whole lot we can do to prevent. That's just one of the side effects that's going to happen. Potentially could happen, I should say. Doesn't happen in everybody, but that's just something that could potentially happen. Sometimes it's permanent, sometimes it's not. If it starts to happen, the doctor typically reduces the dose to try to prevent it from becoming permanent, but it's just a side effect of it. The next one is renal failure, and the renal failure, this is what's scary about this drug and why I said it doesn't kill human cells except for the kidneys. Renal failure will occur in up to 80% of patients. So that's not something that might happen, that's something that there's a pretty good chance it's going to happen. 4 out of 5 patients will develop renal failure from this drug. Most of the time it's reversible, so we can save them and get the kidneys function again. But for that reason, it's really important to monitor their labs, particularly their BUN and their creatinine. Rule of thumb, BUN should be less than 29, creatinine should be less than 1.6. If those numbers start getting high, it might be time to try to decrease the dose. Now, the renal failure is going to be more common in the IV form, but it certainly can happen with the oral form as well. The next one's pulmonary infiltrates, which simply mean pneumonia. And then the rest are stuff that's not going to be deadly, but they're super obnoxious to the patient. So like a headache, fever, chills, nausea, and vomiting. What we'll do is about 30 minutes prior to starting this, especially if we're giving it IV, is we'll try to pre-medicate them with a couple different drugs to help reduce this. So we'll typically give them an antipyretic to prevent both the fever and the headache. So we'll give them Tylenol to help prevent a fever, and then to prevent the headache as well. We might also give an antihistamine and an antiemetic when those two are given together, and we'll learn about antiemetics here in a little bit. It helps prevent the chills and the vomiting that's associated with this infusion as well, and the nausea too. So we can do a couple things to make life a little bit better for these patients, and that would be one big thing that would be important to remember to do, because if you don't do it, they're going to feel like they're turning inside out and that they're dying. So be kind to your patient, and if you can prevent something, try to do it. So important to get their Tylenol in them. You're not going to use ibuprofen though, because ibuprofen is also hard on the kidney, so you're not going to give them any ibuprofen. Of your over-the-counter medications, Tylenol would be the best one to do. One, it's not going to kill their kidneys, and then two, it's also going to help reduce their fever as well. Some of the different routes for amphotericin we have are oral, injectable, and there's actually also a topical form. The topical is not used very frequently, but it does exist. The injectable is going to have the most side effects and is going to also be reserved for the most severe infections, whereas the topical have the least amount of side effects, but it's only going to treat superficial infections. So if you have a systemic infection, most likely be started on injectable, on an IV amphotericin, and then once the infection kind of subsides a little bit, they might go to an oral amphotericin to finish it off. But they'll probably need IV for at least a little while. Some of the interactions with amphotericin include digoxin, which you just learned about for heart failure. What amphotericin does is it increases the DIG level, which can then induce DIG toxicity, so that's no good. 2 is any sort of nephrotoxic drug, so that includes like your certain antibiotics we've talked about, NSAID therapy, so ibuprofen, Aleve, those are all a no-no for these patients. And then the third one I want you to know are the thiazide diuretics. And what happens if they're on amphotericin and a thiazide diuretic is it can cause hypokalemia, which is a low potassium of less than 3.5, and that can induce a cardiac arrhythmia. So it just increases the risk of them having cardiac complications while getting it. Again, it's really important that you're checking their vital signs while they're getting their infusion so that if something's starting to occur, you can catch these symptoms in the early stages versus the late stages, and it's a little bit easier to fix the earlier you catch it rather than the later you catch it. Now, since amphotericin is no fun for people to take, they developed a new drug, and we call it diflucan or fluconazole. Fluconazole is simply the alternative to amphotericin, and it works pretty well. Now, keep in mind there will be certain fungal infections, and you don't have to know which ones, but there will be certain ones where the patient has to be on amphotericin because although it's terrible to take and you feel icky while taking it, it's actually a really effective antifungal agent. So there will be times when we still have to use it, which is why it still exists. However, for certain patients, they can take diflucan instead of amphotericin, and they can enjoy life a little bit more because it's not quite so nasty. It works similar to how amphotericin does in the fact that it stops the production of estrosterol, which then causes the fungal cells to die. Some of the indications here, one thing that this drug does have going for it is it can cross the blood-brain barrier. For that reason, it can be used to treat fungal meningitis, which is pretty exciting. If somebody gets diagnosed with fungal meningitis, that's a really bad sentence to have because it's really difficult to treat. It takes a long time to remember funguses. They grow slow, but then once you start treating them, it takes a long time. So it's a long course of therapy to decrease them. And you really don't want fungus growing around your meninges because that's not going to end well for you. It can also be used for oropharyngeal candidus, which is simply thrush. And then it can also be used topically for topical fungal infections such as athlete's foot. As far as the side effects, they're pretty minimal. When applied topically, there's probably not going to be anything. Might be a little bit of burning, might be a little bit of redness, but nothing that's really going to make you want to stop taking the drug. Now, systemic, there's not a whole lot either. Nausea and vomiting, diarrhea, and stomach pain. The one I want you to really remember, though, is it can cause hepatotoxicity. So for that reason, while people are taking diflucan, they need to lay off the alcohol, and they also need to avoid Tylenol as well. The different routes are going to be oral or injection. Injection is going to be more likely to cause the hepatotoxicity, although the oral certainly could cause it as well. It's just your side effects are going to be worse with the IV source of it. And the last drug you guys need to cover today is nystatin, and this is probably the one you'll use the most often because it's really good at curing our common fungal infection, which is thrush. Now, one thing about nystatin is it's too toxic for parenteral injection. So therefore it cannot be given IV, it cannot be given intramuscular, it can only be given orally, or it comes in a little powder or a cream that you can do it topically as well. When given topically, it's typically for like a diaper rash, a yeast infection. Sometimes we'll put it between skin folds for yeast infections as well. And when it's oral, it comes in a little like syringe that we tell the patients to swish it around their mouth and then spit it out. But my little tip here is patients who have thrush, like the ones I take care of, typically have a closed head injury, so they don't always follow directions as well as they could because they're confused. So sometimes your swish and spit turns into a swish and swallow, which I felt bad the first time a patient did that. And then somebody told me don't worry about because they probably have thrush going through their entire GI system. So since then I haven't felt too bad about it. In fact, I actually kind of encourage them to swish and swallow it in case they have any of that yeast growing down their throat into their esophagus. It'll help take care of that as well. It was a physician that told me I could do that, so that's what I do typically. Side effects are going to be pretty minimal. It can cause some nausea and vomiting. I'm sure it tastes terrible. I've never tasted it, but patients tell me it tastes terrible. It can also cause some diarrhea and abdominal cramping, and when given topically, sometimes patients will get a little rashy from it. I don't really know why, they just do. So that's your last type of antifungal agent. And then for those of you that like a list, here's just the list of the antivirals we covered, and then the antifungals as well for you to look at. And this will be the last lecture for this week. So have a good weekend.